The Neurology lecture series. We've been honored to have Dr. Mike Levitt give talks over the years, and with a great perspective on endovascular care. And this is a hot topic right now, which is endovascular therapy with low aspect score. And so we're honored to have Dr. Levitt give a talk on this. A little bit about Mike. He grew up in Fargo. He went to school in Chicago, and before coming here to the University of Washington, where he did his training in neurosurgery, and then he left to Barrow in Phoenix for a fellowship and in endovascular neurosurgery. And before coming back here again to the University of Washington, where he's one of our four endovascular neurosurgeons, endovascular interventionalists who help us with our large vessel occlusion. So this is a great topic for the lecture series. With that, I turn it over to Mike.
Thank you, Sandy, for the introduction and the opportunity to speak. And I think I know most of you on the call, but it's always nice to see people on. And obviously, we're all friends here. Please interrupt me if there are questions. As with any good talk, I'm not going to attempt to take up the entire hour. So there'll be time at the end for discussion as well. So the topic I was asked to present on is something that we struggle with every day, including a call last night about a patient with this situation, which is endovascular therapy for acute ischemic stroke in patients with a low aspect score or large core. And so I'm happy to speak about that today. These are my disclosures, none of which is particularly relevant here. So it's always nice to start with a case. This is a case of mine from April. It's a 76-year-old male on AFib or with AFib on a DOAC. Had sudden onset of right hemiplegia noticed by, he was with his family at the time at 4 p.m. A very high stroke scale at an outside hospital at 4:30, and got us, this was not here, but one of our, part of our hospital system, got a CT shortly upon arrival there, which I'm gonna scroll through here on the left. So at around 4:40 p.m., so shortly after presentation, aspects was rated as a 9. Remember, he had right-sided symptoms, and they were calling a small amount of attenuation in the MCA territory. And then he was transferred here to Harborview, and his scan shown on the right. Took a little while to get here, but you can see, I'm sorry, the windowing is not quite the same, but I think you can appreciate on the left-hand side here that there's quite a bit more cortical attenuation on the left and some asymmetry. It's not actually as easy to see as you might think, but this was rated as an aspects of 3. This was his CTA, and I think it's a carotid T, so carotid terminus occlusion. I think what's important to note here is not only is there a cutoff here, but you can see there's a complete absence of vascular marking here. So really poor collaterals as well. He was referred for endovascular therapy. And so we did a quick thrombectomy. You can see a lateral projection angiogram here with a cutoff of the carotid ending just after the ophthalmic artery. I think one pass got complete reperfusion of all branches for a TICI-3 complete reperfusion. And then this was his post-op scan with, as you can see by now, just substantial amounts of edema, some new subarachnoid hemorrhage, and then he went on to very shortly thereafter decompressive hemicraniectomy and failed to recover and eventually died. So, here's a case where clear fast progressor with a low aspect score of 3, where we got a very quick thrombectomy once he arrived here with good first pass effect, but still ended up doing pretty terribly with intracranial hemorrhage as well as rapid progression. So obviously you show these cases because you want to provide context to show that even in the area of complete reperfusion, we weren't really able to help this gentleman, and the difficulty is trying to figure out those that we can help. So that's sort of been our usual practice. So the 2015 stroke trials really established a clear benefit primarily for an aspects of 6 or higher. Again, to remind everybody, aspect score is a 10-point scale, higher being better, lower being worse, and you lose points for areas of attenuation on, primarily it was based on CT, although it's been adapted for MRI. And those are areas of attenuation that are considered completed infarct. So a 10 would mean there's no complete infarct. It's complete, all the parenchyma seems to be fine. A 0 means that the entire hemisphere, basically the entire MCA territory and deep structures are already infarcted, or at least show signs of that on imaging. The stroke trials demonstrated a decisive benefit of thrombectomy, but were really primarily limited to an aspect score of 6 or higher. So patients where less than a third of the MCA territory was affected. Those that were less than 6, there's been a lot of debate. So this article just came out a few months ago. It's a clinical trial out of a multi-center study out of Japan, published in the New England Journal. And it looked particularly at thrombectomy versus medical management for patients with large vessel occlusion with a low aspect score of 3 to 5, presenting within 24 hours of symptom onset. And what they found was encouraging. So this is one of those, as we all have seen in stroke trials many times, this classic modified Rankin score shift. 0 in white, that's completely unaffected. 6 in dark blue, that's dead. And the shift between the endovascular therapy group on the top, about 100 patients, and the medical treatment group on the bottom, 102 patients. And what they found was the odds ratio for what they considered a fair outcome, a modified Rankin of 0 to 3 at 90 days, was statistically significant, 2.43 with endovascular therapy. But they did find a significantly higher rates, 20-something% of symptomatic intracranial hemorrhage with thrombectomy, and a much lower rate with medical treatment. And important to note that the 2015 stroke trials used a good outcome, modified Rankin of 0 to 2 at 90 days. This used a 0 to 3. The 0 to 2 was not significant in favor of endovascular thrombectomy. And so regardless of that, the article concluded that in patients with a low aspect score of 3 to 5, thrombectomy was beneficial in preventing bad outcomes, improving fair outcomes, and should be considered in this patient population. And so if you just read the title and the abstract, I think the debate is pretty settled. The problem is that, hopefully you don't just read the title and the abstract. So there are a couple of things about this trial that give us a little bit of pause. Very encouraging, but give us a little bit of pause. So first was the good outcome. They didn't use a good outcome, they used a fair outcome. So MRS 0 to 3 at 90 days, not MRS 0 to 2. MRS 0 to 3 is pretty contentious as far as what the sliders, where the boundaries of good outcome should be. And we'll talk about that later. But it's not the same takeaway as the 2015 stroke trials. So it's not the same effect size as those trials, because the proportion of patients with what would be considered a good outcome, meaning independent at 90 days, 0 to 2 modified Rankin, was not statistically significantly different between the two groups. Most of these patients received an MRI, not a CT scan. That's standard of care in most stroke centers in Japan. And so there is some likelihood that the MRI is going to provide a more accurate estimation of the core than the CT. And when I say overestimate core, I don't mean it overestimates the core. I mean it accurately estimates the core. CT aspects probably underestimates the core a little bit because it is a less precise imaging modality. And so a translation of an aspects of 3 on an MR may mean closer to an aspects of 4 on a CT, again, depending on how you window it and what you're looking at. And it may not be totally transferable or generalizable to a CT scan aspect score. So not quite an even comparison. Some other things that are, I think, less influential or less important, but still of note, is that despite 2/3 of patients presenting within 4.5 hours of symptom onset, only less than a third received TPA, which is, I think, pretty far outside of what we would consider typical in other countries or other markets. And those that did get TPA got a lower dose, which is pretty standard for predominantly Asian populations, 0.6 milligram per kilogram instead of 0.9. There's also this sort of theoretical, which I think is less of a specific criticism, that acute ischemic stroke patients of Japanese descent have a higher incidence of intracranial atherosclerotic disease than those in other countries, and that may also influence outcomes. Those last few are sort of mild criticisms. I think the main issues with this trial is, number one, establishing what your primary outcome is, which is modified Rankin of 0 to 3 at 90 days, not 0 to 2. And then also the generalizability of an MR diffusion aspects compared to a CT aspects that make it not quite as straightforward of an application as we might think. So I wanted to take some time to review, beyond this trial, the data to date on large core or low aspects stroke patients and thrombectomy, because there is actually quite a bit of information out there that's kind of buried in certain places, and then talk a little bit about what we know, what we hope to learn with future trials, and then maybe some discussion about how our group can approach these patients when it is 2 in the morning and we might be talking about doing thrombectomy.
Hey, Dr. Levitt. Dr. Levitt, Rajiv, I have a question.
Sure.
Did they do perfusion imaging for all those patients, or any of them? Or
no? So we'll get to that. They use diffusion on MR aspects, but we're going to talk about perfusion in depth here in a second. So good.
Sorry, perfusion was what I meant. If I said diffusion, yeah. Sorry.
Yeah, perfusion. So let's talk about this for a second. So this was the Hermes collaboration was a individual patient level pooling of all of the stroke trial, the major stroke trials in the 2015-2016 time period. So there's a lot of information here about patients who are randomized to either thrombectomy or medical management across a wide variety of settings. And what they did was they pulled all of this information from all these trials. So they got all the patient data. So instead of the Mr. Clean trial and the Escape NA trial and the Swift Prime trial, it's all pushed together, since many of the trials had similar characteristics, to give a really fully featured indication of how stroke thrombectomy did in the randomized control trial setting. So the landmark 2015 studies did not have an explicit aspects cutoff, which is a common sort of misconception that the aspects cutoff was 6 or higher. Anything lower than that was excluded. That was not the case. There was actually quite a bit of variability in what aspects were included and not as far as what was allowed. But if you pull all of these groups, there's 800 something patients in each group, the median aspects was 8, and no different between the two groups. So even though it was allowed, and there were some, we'll talk about this, some patients who were who had a low aspects, there wasn't really a whole lot of them in this very large cohort, and most patients had a pretty good aspect score. So what about those below the cutoff? So this study looked specifically at predictors of outcome after thrombectomy and the effects of some of these other characteristics. So here's one of these plots that the box or the dots to the right of the line favor endovascular treatment. The dots to the left favor medical management. The confidence interval here, or odds ratio here, is 1, and the confidence interval is the box and whiskers. So anything that crosses 1 is considered not significant. Your odds ratios over here will show you. So here you can see of those patients in the pooled analysis, their 90-day modified Rankin of 0 to 2. So the primary outcome, independence at 90 days. The control group versus the thrombectomy group, a pretty low number of patients with low aspects, right? So in the 0 to 2 pooled group, only 11 got thrombectomy, 26 were randomized to control. In the 3 to 5 group, a little bit more evenly matched. And then the 6 to 10, which is what the primary trials we're looking at, you can see a lot more patients there. So what we want to call attention to is that the 3 to 5 and 6 to 10, there seemed to be a pretty strong treatment effect. But the 0 to 2, again, very small numbers, wide confidence interval, but no benefit of thrombectomy. Really low numbers, so not super easy to get a sense of exactly how applicable it is. So then they looked at it a little bit further, and they broke it down by the 0 to 2 again, because it's so low, and then each individual aspect score here, 3, 4, 5, 6, 7, all the way up. And what you can see is, again, low numbers, big confidence intervals, but things don't look that great for the aspects below 6, right? All of these here, maybe as outliers here, again, 13 patients in the thrombectomy group probably driving this odds ratio. And you don't want to pick and choose data or cherry pick too much as we get low in the numbers, but there's a lot of confidence intervals crossing the line here. And so again, it's not clear based on the Hermes registry, so this pooled data, it's not entirely clear that there is a benefit of good outcome in these low aspects patients. There's probably, because of the low numbers, more studies needed, which is what we get later. So this is a similar dot and whisker plot for mortality. And this basically shows no real benefit in mortality for kind of really any of these groups, to be fair. There's basically touches 1 even in the good aspects. And that's, again, you do see that there is an improvement in the upper MRS scale, not necessarily an improvement in the lower MRS scale based on aspects. Symptomatic intracranial hemorrhage, again, a little bit similar, not a ton of difference. This would suggest over here on the right that there would be more symptomatic intracranial hemorrhage in the intervention group, less in the control group. It's kind of assumed that as you reperfuse dead tissue, you're going to see a higher likelihood of symptomatic intracranial hemorrhage. This was not significant. Again, low numbers, hard to say. And then the last thing here is, this is just a table format of what I just showed, showing it there was a significantly higher amount of symptomatic intracranial hemorrhage in the low aspects group. So the conclusion from these baseline studies was that there is probably a benefit in large core patients for thrombectomy, but because of the low numbers, there's equipoise, and the cutoff of how low is too low has not been established. There's definitely a higher incidence of symptomatic intracranial hemorrhage, and we're probably not saving lives when we're doing thrombectomies in low aspects or large core, but it's not clear where and how much functional benefit we're improving. Again, the conclusion was there probably is a benefit here, but difficult to say because the studies weren't really designed to look at that in particular. So now, in contrast, here was a relatively recent prospective stroke registry, multi-center trial or multi-center registry in Germany. And this was for patients who were undergoing either medical management or thrombectomy for aspects of 0 to 5. And there was 1-to-1 propensity matching, which is a sort of, it's a reasonable way to account for individual patient variability in a retrospective study. So a reasonable number of patients, so 124 patients in each group, both thrombectomy and medical management, propensity score matching for things like age, time of onset, aspects, location of occlusion, et cetera. And they also looked at the efficacy interaction with thrombectomy. So not just whether the patient got a thrombectomy or not, but how effective was that thrombectomy in reestablishing flow, which is not always, the success of the thrombectomy is not always captured in these trials, which sounds strange, but it isn't. It's a randomization of the treatment to the treatment group, but not necessarily the success of the treatment, right? So this was their 90-day modified Rankin, and the top is the abbreviations just annoy me because people use different abbreviations for everything. This is best medical therapy, and this is mechanical thrombectomy, as if they couldn't figure out a less confusing way to represent these things. But you can see here, so there's only 1, 2, 3, 4 MRS here, because there were nobody in the 0 or 1 scale here. Everybody was either dead or disabled. There wasn't really much of a change here. Sorry, this is a 0. I'll show you the scale here in a second. There really wasn't much of a change in benefit here for thrombectomy, but this was, I think, more important. So sorry, this is a fair outcome, MRS 0 to 3. That's this scale. The gray is 4, the light blue is 5, and then the dark blue is death. And this is their modified TICI reperfusion grade. And so what you can see here, and I think this is helpful to understand, is that the odds of improvement, the odds of a fair outcome, went way up once you got what we consider a successful reperfusion, which is a 2B or a 3. And if you got the vessel open in 2 or fewer passes, a very substantial improvement over best medical therapy, 25. Kind of important to know that if you didn't open the vessel or you got partial opening, those patients did worse than just medical management alone. So again, like, there is a possibility of causing harm in these patients. Small numbers, but important to note. You can hurt these patients with thrombectomy, especially if you don't get the vessel open. And so it's important to look at that as a treatment effect. So their conclusion, and again, it's not a randomized trial, but a reasonable number of patients with propensity score matching, was that there was no general benefit of thrombectomy for aspects of 0 to 5, and that you can see in the top of that modified Rankin that I showed. Higher mortality and higher intracranial hemorrhage, symptomatic intracranial hemorrhage associated with thrombectomy. I didn't show those data, but they were both significant for the thrombectomy group. Their multivariate regression showed that younger patients with better reperfusion were the ones that showed benefit from thrombectomy, which is, I guess, not terribly surprising. But their conclusions was that it was really something that should be approached with caution, because in the all-comer analysis, it was not helpful, and in some cases could be harmful. So those are sort of 2 major looks at the problem. And so I think, to Rajiv's point, so what about perfusion? So Aspects is very convenient. It's been well validated, but it is in the end somewhat qualitative. And remember that an aspect of 7 that involves 3 areas of the MCA territory is the same aspects as an aspects of 7 that involves, like, the insula, internal capsule, and a little bit of the temporal lobe. There's the same aspects, but pretty wildly different functional effects if you think about it. So could perfusion imaging with a defined core or a mismatch, like what we saw with the perfusion guided trials, better detect thrombectomy candidates in low aspect scores? So again, we turn to first the pooled data from the stroke trials, and they looked at that with perfusion imaging and functional outcome in particular. So it's a pooled analysis of stroke trials, like we talked about before. Perfusion imaging was not an inclusion criteria in some trials. In other trials, it was used to exclude patients from thrombectomy if they did not meet perfusion criteria. 591 patients with CTP, 309 patients with MRI diffusion, which would be considered, or perfusion imaging, which would be considered more advanced imaging. And remember, the total of patients in the trial was something like 1,600. So this was a subset of about half. 89% of patients were eligible for and received TPA, and it was the assessed effect of successful thrombectomy on outcome. What's interesting they found is that functional outcome was worse in patients who were selected with CTP compared to diffusion. Not really clear how to interpret that, other than maybe the selection of patients at the centers that use diffusion. Maybe those patients erred to be a little bit better, but they did not pool the results. It's not that important for the bottom line of this talk, but just to understand that they present the data separately. So here is the likelihood of functional independence, so modified Rankin of 0 to 2 at 90 days. And on the x-axis here is the core volume on either CT perfusion or MRI diffusion. So further along this axis, larger core up to 150 cc's on the very right-hand side. The y-axis here, the higher the y-axis, the higher the proportion or chance of good outcomes, MRS 0 to 2. And so what you can see here is that all the curves sort of slope down to the right, which means that you're less likely to have a good functional outcome at a higher core. And the blue line is thrombectomy, the red line is standard therapy. So even though you're less likely to have a good outcome at a higher core, there was a clear benefit of thrombectomy in these groups. So smaller core on CTP or diffusion was tracked with an improved functional outcome. The odds ratio of a good outcome was 0.77 per 10 milliliters of additional core and was higher with successful thrombectomy. But what they found was basically in all instances, the improvement in functional outcome was maintained with thrombectomy. These graphs on the right are the utility weighted modified Rankin 90s. Don't really worry so much about that. But the overall benefit here was they did find a benefit of thrombectomy as related to CT perfusion, even at pretty large core volumes. And this is another sort of example of looking at the efficacy of treatment. So these were in patients who had at least a TICI 2B reperfusion, so greater than 50% of the downstream endovascular territory was reperfused, so successful thrombectomy. And here, again, you can see a significant improvement in thrombectomy patients compared to medical management patients with a pretty good odds ratio, 0.77 per 10 milliliters. This is functional improvement by category, means 0.82 odds ratio for thrombectomy per 10 milliliters for at least improving by one MRS category. The numbers are lower because the lower the scale in the MRS, the better. So significant benefit of reperfusion, especially successful reperfusion in patients which tracked pretty well with their infarct volume. The larger the infarct volume, the less likely a good outcome would be. Makes sense. And then they looked at number needed to treat. So here's a plot of the number needed to treat on the y-axis here, the absolute risk difference, number needed to treat's over here. Lower numbers here are worse. And the ischemic core volume, so the higher you get on your ischemic core, the higher the number needed to treat, so the more patients you would need to show benefit. 90-day modified Rankin of 0 to 2 was the outcome. And so what they found was that the number needed to treat remained less than 10 for core, this wide confidence intervals up to 150 cc's. And here's a 90-day modified Rankin of 0 to 3, which again shows a pretty good number needed to treat. But again, only a small number of patients who actually were included actually had a core of 70 or greater. So even though they show these tables all the way up to, or these graphs all the way up to a ischemic core of 150, really the majority of patients were less than 70, right? And so this upper end is a little bit hard again to say because these are pretty low numbers. Remember that the Japanese trial that we saw had 100 in each group. This is much less than that over 1,600 patients. So again, harder to take away from this a really definitive, yes, it's clearly beneficial. Doesn't really help us. So what is an optimal perfusion cutoff? So again, you can kind of go down the rabbit hole here, but trying to figure out, like, if you're going to use perfusion data, can you track what's the, instead of aspects of 3 or aspects of 2 or aspects of 4, what about a number that can be gathered from either diffusion weighted imaging MR or perfusion imaging CTP core? So this was a prospective registry in Japan of 157 patients. About 1/3 had thrombectomy, the other 2/3 had medical management. So again, somewhat low numbers, but I'm showing this study in particular because I think it represents the data in a nice way. So diffusion core on all patients, and they stratified this into 70 to 100 because less than 70 was considered not a large core infarct, then 100 to 130, and then greater than 130 cc's. And this is a very busy modified Rankin, and so I'll go quickly through it. This top one was the 70 to 100 group. There were about between 20 and 30 in each category. This middle one is 100 to 130. Again, lower numbers, again down to 14. And then this other one was, this bottom was greater than 130, very, very low numbers here that got thrombectomy. The shifts are a little hard to tell. And that's why I think that this is probably the better graph. So this is a good representation of, and just concentrate on the lines here. So red is thrombectomy, blue is medical management. The confidence intervals here, and then the actual number. The higher on the y-axis, the higher probability of a good outcome. So independence, MRS 0 to 2 at 90 days. And then that's placed over this x-axis of the size of the ischemic core volume. And so the higher you get on the x-axis, the larger the core. And then obviously, as you can see here, the closer you get to 0, which means no probability of a good outcome. And what they found was a functional benefit that improved with thrombectomy that would seem to remain significant. And the breakpoint was about at 120 cc's. So 120 mils of core, beyond which it was unlikely that thrombectomy was going to provide a functional benefit, below which it seemed pretty likely that thrombectomy was going to provide a functional benefit. And they found a similar symptomatic intracranial hemorrhage risk cutoff. So around 120, 130, there seems to be more. When you get higher than that with your core, there seems to be a higher amount of symptomatic intracranial hemorrhage on thrombectomy. Again, not that surprising. We saw that in other studies as well. So this study, again, I thought was a good way of visualizing, especially this graph, kind of a little bit of a break point here as far as core volume and outcome. The next study I want to go over just came out at the beginning of July. This was the INSPIRE study group, multi-center registry of 269 patients with large vessel occlusion, CT perfusion, and a core greater than 70. Again, that 70 cutoff seems to be a reasonably well-established cutoff of what would be considered large core. About half had 70 to 100 cc's, again, somewhat empiric. And then the other half had a much larger core, greater than 100 cc's. Half had thrombectomy, a little less than half. And so here's the modified Rankin, the box plot. And what they found was statistically significant improvement in patients who had thrombectomy, both for fair outcome, modified Rankin 0 to 3, and good outcome, modified Rankin 0 to 2, for all patients with a core of greater than 70. So when you look at any patient with a core greater than 70, including half who had a core greater than 100, they found that there was a statistically significant improvement. And the overall number needed to treat for a fair outcome was 6.2. They did see significantly more symptomatic intracranial hemorrhage, 21.1% in the thrombectomy group, 7.1% in the medical management group. And again, this is a prospective registry, not a randomized trial, but the populations were fairly evenly matched. So they broke this down a little further. Of the 135 patients with a core of 70 to 100, they still saw a significant benefit of thrombectomy for both fair and good outcome. And for the ones that had, the patients that had greater than 100, again, a large number of patients, there was no significant improvement. So this tracks a little bit more with the study we saw earlier. Again, the cutoff of 100 mils is somewhat empiric, but when you get to a certain point in a large core, you are not going to help the patients. And this is a pretty large number of patients, 138 in the group, split almost 50-50 with thrombectomy, and it was not beneficial. So, sorry, less than 50-50. It's about 2/3, 1/3 medical management, but not beneficial for these patients. So The number needed to treat for a core value of 70 to 100, thrombectomy 4.1 to reach a fair outcome of 0 to 3. And the number needed to treat for a 0 to 3 of the large core greater than 100 was an unattainable 155, probably because of the low numbers, but you get the idea. So their conclusion was that there is a benefit of thrombectomy for large core, but only for those where the core is less than 100 on CT perfusion. And they seem, again, a somewhat arbitrary cutoff, but if you're going to draw a line, that line seemed to hold up pretty well. So one of the last papers I want to talk about before we go back to the main theme was a relatively recent meta-analysis of all of these data for large core stroke thrombectomy. Included studies that either included patients with an aspects of 0 to 5 and or large core on CT perfusion or MRI. The distinction here is that this is defined as a large core is greater than 50 cc's on CT perfusion or MRI. Most people would not consider 50 to be a necessarily large core. I think most studies are moving more towards 70, but you get the idea. So what they wanted to look at, and I'll show some of these box and whisker or these forest plots, is they wanted to look at whether endovascular therapy was favorable by pooling these data. So here is the data for aspects 0 to 5 only. So only studies that use aspects, not perfusion imaging. Their 90-day good outcome 0 to 2 still had a pretty good effect in favor of thrombectomy. And that was pretty significant odds ratio. This was the studies that only used perfusion greater than 50, core greater than 50. And again, you see a little bit messier data, but again, favors thrombectomy with a pretty good odds ratio, again, for good outcomes, 0 to 2, not fair outcomes, 0 to 3, good outcomes, 0 to 2. They did not find an effect for both CT and for core, high core perfusion on symptomatic intracranial hemorrhage, no difference, which is a little different from what we saw in those other trials. And then mortality, they found a mortality benefit favoring thrombectomy for both aspects and for perfusion, large core and perfusion imaging. Then they pulled all this stuff together and said, all the studies, whether aspects 0 to 5 or perfusion core greater than 50 or both. And again, what they found was it favored thrombectomy with a pretty good odds ratio, significant. Didn't seem to be a statistically significant effect of thrombectomy on symptomatic intracranial hemorrhage. The line crosses at 1, so you can't really say this is significant. Seems like there's kind of a mix here. And again, this kind of reflects that some studies found that there was a higher incidence of symptomatic intracranial hemorrhage with thrombectomy and large core. Some didn't. Hard to know. Mortality seems again to favor thrombectomy, including in these large core. And so the conclusion from this updated meta-analysis was that thrombectomy, in their opinion, seems to be beneficial across all groups, including low aspects or CTP core greater than 50 or both. There was no association with symptomatic intracranial hemorrhage mortality. And the usual caveats apply here that there's somewhat heterogeneous data, and also the numbers as you get lower and lower in the aspects. This study wasn't really designed to tease apart the aspects of 5 versus the aspects of 2 compared to some of those other studies. But the results seem to be somewhat convincing, and I think we're starting to see this in this Japanese trial as well, that there does seem to be a benefit in these large core thrombectomy cases, but where you draw the line, where you tip over from benefit to harm is harder to assess. So now I kind of want to ask the group, again, we'll see this same aspect score of 3 thrombectomy patient. And of course, we know the outcome was bad, but does anybody think that these patients should be getting thrombectomy every time? Do we think that the data support that? Is that kind of where we're headed as a group? I think we should consider that. I see a chat thing in the chat. Oh, that's better. And then I just want to talk about my conclusions from doing, I was very actually pleased to be invited to do this talk because it gave me an opportunity to really dive very deeply into this topic and get an understanding of what we know and what we don't, and then come back to the group and see what people think. So you know, my conclusions from reading this is there's no question in my mind that there is a benefit to patients with an aspect score below 6. And I think we see that in anecdotally, and we also see that in the existing literature, both the randomized trials and the registries. It's clear that 6 was always an empiric cutoff and always an imperfect one. And we can all think about patients who did well despite a low aspects. So there's almost certainly going to be a benefit. I think the benefit is probably going to be clearest for those with an aspects of 3 to 5 and a corresponding core of 100 milliliters or less, because the data seem to support that the effect size was much larger for both a good and a fair outcome in those studies that looked only at these aspects or these core cutoffs. And then certainly patients that are younger with better collaterals are going to do better no matter what, right? And then better reperfusion seems to be an independent, for most cases, seems to be an independent predictor of better outcome, regardless of any of this stuff. So if we can get the vessel open quicker with less passes, that's obviously going to lead to some of those patients doing better. The ongoing trials and what they're trying to answer. So there's many trials that are trying to answer this question. The Rescue Japan Limit trial, which is the New England Journal trial that I had put up, that's the only one that's been published so far. But the other ongoing trials are tension, which is aspects of 3 to 5, Tesla aspects 2 to 5, or diffusion 70 to 120, in extremis diffusion aspects 0 to 5, and select 2 aspects 3 to 5 or core greater than 50. They're all going to measure things a little bit differently, but they're all going to give us a pretty similar idea of that 5 or less cutoff. Some of them, as you can notice, don't go down to 0. So we may not have, besides this one, we may not have good data for patients with an extremely low aspect score for some time, if ever. But something to think about in the future. I see Dr. Kaiser said he would assume that since the patient had poor collaterals and the core was quite large, the increase of complications decreased likelihood for good outcome for that case that I showed. I would agree, it's easy in retrospect. And even at the time, we knew the patient was going to do terribly because he was a fast progressor, because he had poor collaterals, because his aspects went from 9 to 3 in about 3.5 hours. Should we exclude those patients? You know, were they going to die anyway? Are they going to have terrible outcomes anyway if we leave them alone? These are the questions that we struggle with. And so the questions remain. Oh, I saw another chat. What is your number needed to treat in patients with low aspects to make EVT worthwhile? Great question. 1 second. So the questions are almost done. So, you know, I don't know if Claire is on the call. I always look forward to seeing if she's here, Claire Kreutzfeld, because she talks about this a lot. So we talk about functional outcome. Expanding the primary outcome to 0 to 3 is not without cost. You know, what is the definition of an acceptable outcome, and what are the number needed to treat questions that come up because of that? You know, in the intraparenchymal hemorrhage trials, to look at like surgical evacuation for intraparenchymal hemorrhage, those primary outcomes are 0 to 3. That's considered primary outcome as fair, and that's because the prognosis overall is so dismal. Is 0 to 3 a reasonable primary outcome for large core thrombectomy? You know, maybe, but what you consider as acceptable or primary outcome, and where the number needed to treat is, as the question in the chat, what's the right number needed to treat? I think these are really tough questions. You know, the number needed to treat for CPR for sudden collapse and cardiac arrest is in the 20s. And the number needed to treat for a patient meeting dawn or diffuse criteria for thrombectomy is 2. But there is a lot of resources brought to bear on doing these thrombectomies. And this raises these uncomfortable questions about resource utilization and futility, which is, it would be nice to be able to offer thrombectomy to everyone all the time, but we're going to run up against some of the realities of limited resources, limited healthcare resources. And so, like I said, there is a lower bound beyond which there is probably a futility. Every patient who comes in with a massively large core and no collaterals, we're never going to be able to really fix those people. Should we be subjecting them to a thrombectomy that's only going to increase the risk of intracranial hemorrhage, maybe mortality, but not improve their outcome? Again, I can't answer that question, but I think those are the types of questions that these pushing the boundaries of these trials tend to provoke. And so are we going to continue to end up with this case by case basis question? I don't have any good answers for the group other than I think there is a lower limit. I think 6 is probably exclusionary for aspects, and that right now my read and others' opinion of the Japanese trial is very encouraging that this is beneficial in patients with a larger core, but difficult to generalize based on that trial alone, that we should all shift our practice now to doing thrombectomies on every patient with an aspects of 3 or more. Again, I turn it back to the group, but I don't know that I'm entirely convinced yet. And so with that, like any good presentation, we'll end 15 minutes early, and I welcome any questions.
Thank you very much, Mike. And we'll open up to questions. One thing I would add on that paper as well is that not only did they not use perfusion, but they also 3/4 of the patients were within 6 hours, and they used MR flare to exclude people after 6 hours, which is also just not something we do typically. But anyway, with that, I'll open up to questions from the group. Please just unmute yourself and shoot away.
Hey, hey, Dr. Levitt, it's Rajiv again. Thank you again for a very clear summary as always. Great talk. The data you showed on success of procedure and TICI scores was pretty convincing, pretty impressive actually. Do all these have all these large core studies and these upcoming trials, do they control for that?
Yeah, so you're talking about the interaction effect of successful reperfusion. So it's often not captured in the primary outcome. So the top line takeaway is often not, if you look at the MRS box plots, it's thrombectomy and medical management and how those shift. It's not thrombectomy with successful reperfusion and medical management. So we're gonna have to look a little bit deeper into what will be considered a secondary outcome, which is the interaction term between outcome and successful reperfusion rather than outcome and whether reperfusion was attempted. I think it's pretty clear that if you're randomizing somebody to a treatment that's supposed to open the vessel and you don't open the vessel, you're exposing the patient to all of the risk of that treatment without any of the benefit. But it's a necessary inclusion that you can't just cherry pick and say, well, if it's successful, it's great. If it's unsuccessful, it's not. Therefore, it always works, right? Because there's always going to be some number of patients where you can't get successful reperfusion. But these new trials coming up, I don't remember the specifics of which ones are which, but they're often listed as secondary outcomes that they look at the interaction between successful reperfusion and functional outcome, but it will not be their primary outcome. So the positive or negative nature of the trial is not going to include that depth of detail compared to just the assignment of basically intention to treat analysis.
But it shouldn't include, this is Christina Mara, it shouldn't include whether it's successful or not, because you need to be able to counsel the family.
Exactly. No, it's exactly right. That's what I was saying kind of at the beginning. I probably didn't explain it as well as you just did in one sentence, but you can't cherry pick the successful outcomes before you start the treatment. You can't look at a patient and say, well, we're going to do this because the successful patients all do great. If the unsuccessful ones did so much worse that it brought down the outcome to equipoise with medical management, you wouldn't be recommending that treatment, because you can't, as you say, pick up front who's going to get successful reperfusion or not. For instance, if Dr. Godke or Dr. Walker's on call, very high rate of reperfusion. If I'm on call, much worse, dead patients, terrible. So, you got to kind of, you want to be able to kind of, I kid, but you kind of want to look at all comers, and you can't just cherry pick that. It's obviously important to know, but it's not a primary outcome.
Yeah, it's true. I mean, that makes sense.
Other
Hey,
questions?
Mike, to that point, can I just ask, are there factors aside from Melanie and Raj being on call that help us predict whether somebody's going to have successful reperfusion? I know there are obviously procedural factors that we can't control for until you're in there, but are there patient factors that we could be aware of ahead of time?
There are. That's a great subject for a future talk. And I bet you Melanie, not to throw her under the bus because she's doing a case at the UW, but she would probably want to talk about this. So there are a couple of factors. So some is as simple as age. So younger age, you're much more likely to get a good reperfusion because of the ability to get your catheters to a closer position and better, bigger instruments. There are some radiographic appearance. So a short occlusion and a relatively hypodense on CT occlusion compared to a really hyperdense occlusion can be a factor. Also where the clot comes from, whether it's a super hard atrial clot that's been rolling around, gathering up layers and layers and layers of clot before jumping out into the brain, or a fresh artery to artery embolus that's really soft. It can be easier or harder to remove, as well as where it lands. So a carotid terminus, much harder to get good first pass reperfusion than a proximal M2, for instance. So there are radiographic criteria to suggest patients who will probably do better. It's not so easy that we can just say, oh, you're clearly going to be a disaster where there's no way we can get to you, therefore we're not going to do it. But you can have that conversation with families saying, as we do with, especially with elderly patients, like it's harder to be successful. It's harder to be successful quickly. And it's harder for us to feel confident that this is going to have that crushingly significant benefit that we would see in the trials in your particular situation. So it's a long answer to your short question, but there are factors that make it easier or harder that you can identify up front, but there's no silver bullet to say this is always going to be good or this is always going to be bad.
Will Longstreth, Mike, and great talk, just wonderful review. And the age thing really does bother me, especially when you start getting into these lower aspect scores and larger perfusion volumes. I mean, hopefully they'll look at it, and I think it really does get to the point of the futility. How much are we going to spend for what we get? In any case, that will be a difficult question to answer. So it seems like all of these studies, whether they're observational or randomized, the question of is the best medically managed group disadvantaged? These obviously aren't blinded, investigations, and I sometimes wonder if some of the negativity of this person only getting medical therapy affects the outcomes, especially in some of those studies where the death rates in the medical group are so high. Are they moving, especially the observational, are they moving towards less support and towards comfort measures only earlier than in the group? The decompression in your case was an example of that, where are people who get the mechanical thrombectomy more likely to get than the decompression, because there's a sort of an enthusiasm that we've invested so much, where that doesn't happen in the medical group. Anyways, again, it's going to be very hard to address because these are never going to be blinded studies.
I think that's very well said, and I think I would encourage everybody to read the accompanying editorial about the Japanese trial in the New England Journal, which I thought was very illuminating. It was out of Boston, and the conclusion was, I'm not convinced. And he talked a lot about this idea of how good is good enough for our functional outcomes, and also he made that direct comparison of the decompressive hemicranie literature, which again supports that surgery in chasing it will consider a fair outcome, which leaves more patients not dead, but severely disabled. And I think you're right. I think that we are, and again, I think Claire talks about this a lot, but surgeons, particularly neurosurgeons and VASP particularly, and then also obviously all of us in medicine are pretty bad at prognosticating patients, especially with acute disease. We're pretty bad at accurately estimating functional status. And so it becomes this double-edged sword where you can either be too enthusiastic and want to throw everything at the patient, or you can have that resigned futility, which definitely clouds these registries where and I think we take these with a grain of salt, where patients who got medical management did pretty poorly. I think we always have to take a lot of caution when we look at those registries, and even if their propensity score matched, they're still not a substitute for all of the non-objective criteria that are used to decide some patient's care. So I agree with you. I think it's sticky, and that's why you can only use those data so much before you run into the inability to generalize. Other questions? Sorted. So we've solved nothing. We are still in the same place we were, which is case by case basis. And we're still going to argue over this at 2 a.m. But maybe we get a little closer to understanding the landscape as we get more data from some of these new trials, which should be coming in, I think, fairly soon. Solved nothing and agreed. Thanks, Ariel.
I would add that I took care of the patient that you presented, and I think we were on at 2 a.m. to discuss this. But the patient's family did withdraw life-saving treatment, but they specifically asked me to pass on to the person who did the procedure that they were very happy that the procedure was done, even though it was ended up in. They just felt that they gave him a chance, and so
Yeah.
this is very difficult decisions not only to have between the neurologist and endovascular interventionalist, but also between the team taking care of the patient and their family. So I think it's quite a challenge, no matter how you look at it.
Yeah, and I remember that family very well. I spent some time with them, and that's a great example of something that's not captured, of course, in any trial, right? A 90-day modified Rankin is an incredibly blunt instrument. It's the worst measure except for all the other ones, right? So, we got to use something, but it certainly doesn't capture even close to any of the nuance that we would hope to see in these trials.
Should families be the people who decide how these resources are used?
I'm sorry, say that again?
I mean, should the family be allowed to decide that these resources be used?
Well, we only have 3 minutes left to discuss all of paternalism in medicine, so I don't know that we're gonna answer that question. But
until we change our medical system so that individuals don't get to decide on resource use, we're going to be screwed.
I think, to Will's point, some of that happens to some extent already. I mean, we don't give patients or patients' families the option of a treatment that we at least estimate or perhaps know from evidence is futile or harmful. We don't give them the option to choose, or at least I hope we don't. We shouldn't, if we have strong evidence. But I think you have to be really careful that you are not imposing your own value system on a patient or their family to withhold something that, again, a modified Rankin of 3 might be unacceptable to one patient or patient's family and wonderful to another patient's family. I think it's really very difficult to decide that. And that's not just with thrombectomy, that's kind of with all of these treatments.
Just that we don't have, strong data, the data that we need. And it's a slippery slope, you're right.
And I would add that this procedure on this patient came out the actual day that New England Journal paper came out. So they could have very well cited that paper and said, please proceed.
I think, again, like you can look, I mean, for a lot of these early emerging studies, it's a Rorschach test. You can look at it and see it however you want. You can look at the study and say, this clearly shows a benefit. We should change our practice. Everybody who comes in with an aspects of 3 to 5 should get a thrombectomy. Or you could look at it and, like me, and say, well, I'm not entirely convinced, and here are the reasons why. We need more than one trial. And I think that's why with the thrombectomy trials as well, we needed quite a few goes before we got to the point where we're at now. And here it's going to be harder because we're trying to establish a lower limit instead of just establishing that there is a benefit. Now we have to establish a lower limit. It's much harder.
All right, we are out of time and it's late where I'm at, so we'll wrap it up. Thank you guys very much for joining, and we'll do it again soon. Thank you very much, Mike.
Thanks, everybody. See you later.